So after you have a very interesting career, we are now having this conversation essentially 20 years after you were president. And in that interval of 20 years, you've done some very interesting things. Do you want to chat about that a little bit?
Sure. Should I just sum them up?
Let's start there.
Sure. Well, after I left the society, I went back to my role in managed care and was recruited not about the next year to be president and CEO of the Massachusetts Association of Health Plans. Mm-hmm. So I actually ran a small organization in downtown Boston and represented the health plans. I learned a lot about policy and the legislature, so I used a lot of the connections I had and the experience I had at the Medical Society and helped the health plans. One of the reasons the health plans wanted, and this is a job generally held by an attorney. The attorney preceded me and came after me. And I was there for 8 years, and I think they uniquely wanted a physician to basically work on healing the rift between the health plans and the Medical Society. And it's interesting you brought this up because I was at the Academy of Managed Care Pharmacy about 2 weeks ago where I gave a talk on ACOs and IDNs. It's a national conference of pharmacists who are involved in managed care. And someone from the pharmacy industry came up to me, remembered my time at MAP, because I did a lot of public health issues. So we talked about the importance of vaccinating against flu for healthcare workers. When I was at MAP, and also when I was president of MMS, only about less than a third of healthcare workers got flu vaccines. And now many organizations and healthcare hospitals require you to get vaccinated. So I helped start that conversation. So I used my time at the Association of Health Plans not only to advance health policy issues for the health plans, but I also used it to use it as a public health forum. Because actually health plans do a lot in the public health space that's not well recognized. And anyway, to get back to the meeting, I was at, the person I was talking to said, we really miss you, because she's still an auxiliary member of the Association of Health Plans. And she said, because they don't do anything in health policy anymore. They're just strictly a lobbying organization. So,
interesting.
It was interesting that she could reflect on that.
Yeah.
So one of the things I did when I was at the Association of Health Plans, and I was there 8 years, so I had a really long and interesting tenure there, is that I worked with Governor Romney on his universal health care in Massachusetts, both in terms of the planning of it and the implementation of it. And it occurred to me, being sort of a strategist, that that was really a forerunner for national health reform, which did actually occur when Obama was elected. And then I also thought that we were going to be have these organizations called ACOs, or Accountable Care Organizations. So at that point, I had spent 8 years at Health Plan Association. It was a great ride. I loved it. It was fun. I did a lot of health policy work, but I'm not a natural lobbyist, and it wasn't really what I wanted to do for the rest of my career. My passion is transforming healthcare and really making healthcare more patient-centric. So I kind of felt that when Obama got elected that ACOs were coming, and so there were none at that time in Massachusetts, nor were there likely to be one for several years. So not being a patient person and being someone who recruiters call all the time because of my background, I got an invitation to interview for a job in just outside of Austin, Texas, at an organization called Scott and White Healthcare. And that's an integrated delivery network. And I've actually written a couple of papers and given presentations on both ACOs and integrated delivery networks based on my experience in those organizations. So I moved right in the beginning of 2010 to Central Texas, where I was the CMO for the health plan within a big integrated system that covered most of Central Texas. Central Texas being big and open with not a lot of people.
Right.
But big geographically. So it had some challenges from an epidemiologic and demographic point of view that don't exist in New England because everything's so close together. And then they merged, that system merged with Baylor, so everyone in the C-suite went their own way, as is these mergers and acquisitions happen. And then I've sort of been on a little journey since then. I spent 6 months in Idaho as basically an itinerant medical director for a health plan up there. And then I spent a few years at Highmark, which is the Blue Cross Blue Shield of Pennsylvania. Pennsylvania, Delaware, and West Virginia. And I had a great experience there. That's also an integrated delivery system, but a very different one. Very big health plan with 5 million members, a small delivery system with about 1,500 physicians. But I did a lot of work between the health plan and the delivery system since their partnership was new to try to help them figure out how to work together. So from there, I actually left to, because I needed to go back to Texas for family, and I spent the next 2 years basically working for a national consulting firm who, of all things, consulted for pharma. If you know me very well, I'm a big advocate for pharmaceuticals just are too expensive. So while it was an exciting job, it showed me even at my advanced age I could learn some new tricks and new systems. I had to learn how to use a Mac, and I had to, basically learn the consulting business. It took everything I knew and flipped it 180 degrees because my job was to help pharmaceutical companies get access to health plans and integrated delivery networks. So, it's a little tricky. And then I got another call from a recruiter to come back to managed care, and I miss New England. And I just, Neighborhood Health Plan in Rhode Island is a plan I knew well. They were having their 25th anniversary, and it looked like a really good fit because 1 out of every 5 Rhode Islanders belongs to Neighborhood. And even more importantly, half of the most vulnerable and ill and complex patients or members belong to the plan. So it was a wonderful, and it's a small enough state geographically that things that were hard to do in Texas would be hopefully easier to do in Rhode Island in terms of transforming care. So that's where I'm here now.
So this experience, I mean, with your sort of being a student of organizational behavior and systems and your involvement with the healthcare system in so many different ways, what would you say were the biggest differences between the healthcare system in, let's say, 1999 and the healthcare system today?
There are so many.
Just from a patient's point of view, I guess.
I will say what's alike.
Yeah.
One of the things that's drawn my attention for the 40 years I've been in healthcare is the cost of healthcare. There hasn't been a year where that wasn't a sentinel issue.
Sure.
And it's only gotten worse. And there's no end in sight. I don't know how that's going to be solved, but it needs to be solved. Healthcare, we do not have the highest quality healthcare in the world, yet we certainly, by a long shot, have the highest cost healthcare. And we somehow have to figure out how to improve our quality and manage our costs better. So that's something that I've had a lot of interest in. That problem's only gotten worse. I don't have a solution, but neither does anyone else. Nothing has worked, and all the other solutions I see on the table are only going to make it worse.
And access? What's happened to access?
Access is both improved and not improved. It depends where you are. It depends what you need. I think access to specialty care is much better. Access to primary care and to behavioral health is much worse. And we have literally a crisis in behavioral health right now. Nationally, particularly in pediatric children's behavioral health, I wouldn't even say we have a fragile system. We don't have a system. We have very little access. It's a very sad situation. And behavioral health in general is fragmented and fragile, and very balkanized, in my opinion. I think that our emotions are not that separate from our body, but yet we've managed to separate the two in the healthcare system quite strongly. Access to specialty care is very easy in America, with a few exceptions. There are some specialties that are getting harder to get to. Access depends a lot on where you live, too. If you live in an urban area, access is generally very easy. If when I was at Highmark and we were dealing with West Virginia, which is mountainous and rural, access is a big issue.
Sure.
Central Pennsylvania, which is very rural, very big issue. So I think we have almost a patchwork quilt in terms of access, if that is helpful to you.
Capability of medicine and capability of the system?
Well, that's also a mixed bag, so to speak. I think we're exceptionally good at high-tech, innovative, cutting-edge care. I don't think we do kind of ordinary primary care and routine care, even routine specialty care, very well. I think we have a big opportunity to do more evidence-based practice. I've always found it ironic that as a physician I was trained in science, but as practitioners we sort of we ignore a lot of it. We do one-offs, and that's, I think that detracts overall from quality.
Yep. Well, that's an interesting point, because what you're saying is that physicians need to be trained in understanding the guidelines and in understanding the evidence and in the commonalities of treatment, but also trained in the ability to recognize the exceptions and not to necessarily view every patient as a one-off, completely unique thing, but by the same token do that blend of how are they the same and how are they different.
Yeah. The other thing I'd like to mention that I think is a very important trend is that when I started in healthcare, which is a long time ago, most hospitalizations and most illnesses were intercurrent illnesses, acute illnesses. What's happened in the last 40 years is that we have become a society of people with chronic diseases, and a lot of conditions like heart attacks used to kill people almost always. Now they've become a chronic disease.
Right.
Cancer, in many cancers are a chronic disease.
Right.
HIV has become a chronic disease. Hepatitis C is not only a chronic disease, but now we can cure it.
Right.
So much so that I just learned recently that organ transplants are going to be allowed for people with hepatitis C because they can just take a course of treatment, and because it adds tremendously to the cost.
But it makes organs available.
But it does increase the supply of organs. So I think that if I had to reflect, I would say the medical education and training and even some medical practices haven't really adapted a chronic care or population health model as much as they could.
Right.
Because they're still dealing with the acute care. And I think as we move ahead, the trend I'm seeing is that more and more care, as the technology improves, is being moved to the home or outpatient area, and less is being done in the hospital.
Right. Right.
And that will continue. And as that continues, I think we need much better understanding of things like social determinants of health, barriers and issues that affect healthcare for people who have chronic diseases that don't have a cure for them. Because those are lifelong conditions. And we now have a large percentage of our adult population, at least, with chronic disease.
Right. Right. Which I think is one more thing. Physicians are integrating their practices, but I think the healthcare system needs to be integrated into the rest of society and apportion certain parts of it to something other than healthcare. The social determinants aren't necessarily within the capacity of the healthcare system to address, but
I do
but should be
understand
addressed.
that, but we somehow have to figure out how to incorporate them, because a lot of far more health is influenced by these social determinants of health. Something like 70 or 80% of someone's overall health is influenced by social determinants of health, and only 10 or 20% is influenced by healthcare. Yet we made this huge investment in the healthcare industry, and of which we're all part of. And while healthcare is very beneficial, we're as a society not addressing some of these other needs that equally, if not more, can affect health.
Right, and the cost of healthcare in many ways is crowding out addressing the other issues.
Yes, well, it doesn't leave a lot of money. So, for
Right.
example, neighborhood has a Medicaid plan, Medicare and Medicaid dual eligible plan, and then has an exchange plan. We only do government business. And I have patients where the major access to their care is that they're homeless, and I've moved housing specialists from one line of business to the other, so that we can work on reducing some of those barriers.
In some ways, I think your health plan is functioning as a mini government in taking care of your population. So let's then back up just a little bit and talk about your career between residency and becoming an officer in the medical society. What sorts of things can you say about your career as it evolved?
Well, I started in academic medicine. I'm a board-certified clinical geneticist, which is pretty much an academic specialty. At least it was at that time. And I was one of the first to be certified as board certified.
Sure.
So, I trained actually about 15 years before boards were existed in clinical genetics. And there's still only a few hundred clinical geneticists across the country. It gave me a very different perspective because unlike traditional specialties, clinical genetics crosses traditional specialty lines. So you can have a genetic disease affecting heart disease, GI, bones, neurology. A lot of neurologic diseases are genetic, cancer. So, and then of course birth defects. I was a specialist in birth defects, among other things. So, and while I was there at Tufts, I worked on I started doing computer decision support.
And this would have been in the 80s, or?
This was in the late 70s and
Wow.
80s and early
Okay.
90s, yeah. So I worked on one of the earliest clinical decision support systems. Again, it was focused on clinical genetics, but it was the first one actually marketed to practicing physicians. And I had an international base of users. It wasn't very profitable, but it taught me a lot.
Yeah.
Yeah, I learned a lot about things other than healthcare.
Yeah.
It also taught me the power and the problems of decision support. So I've always had a small interest, although I'm still a student of technology. I'm continuing to evolve, and that's another trend during my career is that the evolution of technology. There are people born today who have never had a landline.
Right.
I actually don't have a landline. I gave up my landline about 15 years ago. So. But there are people today who've never used a rotary dial phone. So, that just changes your perspective on things.
Yeah.
And I tried with my decision support, it adapted it from the days from when the internet was actually called the ARPANET and worked from MIT, and it was sort of a hodgepodge thing, to it becoming, the powerhouse it is today. I also worked on a database of clinical genetics and published a book called Encyclopedia of Birth Defects.
Wow.
That came out in 1990. I had moved from Tufts at that time to become the chief of clinical genetics at Boston Children's Hospital. Anyway, I did that for a few years, and then I moved into really executive healthcare. I became the medical director for a facility for the mentally retarded, actually right here in Waltham, which was called the Fernald School.
Yep.
So it was a 24-hour facility where severely impaired, mentally retarded, and seriously mentally ill people resided. And I did that for about a number of years. While I was there, I went back to school and got a master's in medical administration and preventive health from the University of Wisconsin in Madison, which is a great thing to do. I really enjoyed that.
Yeah.
And then following that, I actually changed my career and moved into, I worked for what was the, I guess you would call it now a QIO. It was called a peer review organization.
Yeah.
I worked for MassPro. I was the medical director there and worked on a Medicaid program. And then from there, I got recruited to be a medical director and ended up being medical director for some time with the Blue Cross of Rhode Island and then Maine and then From there, I went to, I spent 4 years at United Healthcare, which brings me up to the year I became president of the Medical Society.
Right. Wow.